Well, welcome everyone. Thank you so much for joining us this evening for OCD Massachusetts monthly lecture series. My name is Nathaniel Van Kirk. I'm a clinical psychologist and I'm the president for OCD Massachusetts. And tonight I'll be doing a little bit of double duty, and I'll both be the moderator and giving the talk. So just to start off for today's lecture, talking about the relationship between trauma, PTSD, and OCD as it relates to treatment. I'm going to start off with just kind of giving a little bit of information to kind of set the stage for everyone, and then hope to answer some questions that you all might have. And so as we're going through the talk, if you have questions or comments, please feel free to drop them in the Q&A box and in the chat, and I'll try to keep an eye on those at the same time. And then we can take the discussion a little bit in whatever direction would be most helpful as we move forward. And so just a reminder that this is being recorded, and also that these will be uploaded on the YouTube channel so that anyone can watch it later on. So as we get going, just kind of checking with the poll real fast. And so it looks like kind of still we have about a 60-40 split of individuals and clinicians and providers. So I really think that's awesome that there's so many people that are interested in this topic. So I do think it's a really great emerging topic, and one that we've started to develop a good bit of research on, and one that for a long time kind of was a little bit behind the scenes. And so hopefully we can have some good discussion as we go as well. And so to get started, I'm just going to share my screen and we'll go over a little bit of some background, some data. What information do we know? What role does trauma and PTSD actually play in OCD, both in its development and in the treatment process? And then I'll talk a little bit about some kind of clinical recommendations, some challenges that as you're going through treatment from both sides, it may be something that you kind of might run into a little bit. And then we'll kind of take questions and answers and take the discussion where it goes from there. And so to get started, when we think about the concept of trauma, PTSD, and OCD, typically these things have been thought of as somewhat disparate or separate, that treatment either focused on PTSD and trauma-related diagnoses or challenges, or OCD. But more recently, we've really realized that there's a lot of overlap between PTSD and OCD, and the role of trauma within OCD is a lot more complex than we previously realized. And so just to kind of set the stage a little bit, when we think about what data we do know that OCD's prevalence rate is about 3.1%. There are some studies that say a year prevalence rate might be a little bit lower currently. It varies based on the study a little bit. But what we also realize is that in about 78% of cases, individuals indicate that a stressful life event. Now, this is separate from a trauma, and I'm going to kind of differentiate between the two a little bit. But we do know that stressful life events tend to be kind of something that kicks off the start of OCD for many people. And so when we're talking about a stressful life event, when we're talking about many of those life events that we all kind of experience as humans that are stressful, they might feel overwhelming at times, they might be really unpleasant. But in the next slide, I'm going to differentiate a stressful life event from a traumatic life event. And part of that is also understanding the way in which skills and strategies we might use, the way that we cope might be a little bit different. But we do know whether or not someone experiences a trauma or has PTSD, that stressful life events tend to be the catalyst for onset of OCD at some point in time during individuals' lives. But when we look specifically at trauma, we actually see that trauma is linked to OCD onset specifically in individuals that don't have a familial history of OCD. And a lot of times what we see is that the onset of OCD in these instances tends to be a lot later in life. Outside of that kind of typical onset window we see kind of in late adolescence, early adulthood, or that the second window that we see in childhood as well. We also have seen some data coming out of the Veterans Health Administration that for those that have high combat experiences, the prevalence rate for OCD might be a little bit higher, around 5.2%. We also found that in about 54% of individuals with OCD reported at least one traumatic life event. And there is some data that's been coming out showing that those with OCD are more likely to have multiple traumatic life events, and that there seems to be an association between the experience of OCD and more life events. I see that there was the email link had a typo in it. Thank you. I'll try to resend that as we go as well. And so when we think about kind of just defining the concept of trauma, I want to talk a little bit about what trauma is. So a traumatic event is an event that poses a threat to an individual's life, physical integrity, or involves sexual violence. And now when we talk about a traumatic event, these are instances where there's real or threatened risk of death, or physical violence, sexual violence, or a risk of what we might call one's physical integrity. One of the things that, and this can include things like physical assault, sexual assault, a natural disaster, war. It can also include unexpected medical experiences. And so that's one thing that's differentiated when it comes to maybe the loss of a loved one, or a medical experience, or something that is predicted, or that someone knows that's coming. So a traumatic life event isn't necessarily one that is expected or that we know is coming, but it's something that's unexpected and poses a threat to an individual's life, physical integrity, or involves sexual or physical violence. Additionally, there's psychological trauma, which is essentially an instance where there's extreme stress that exceeds an individual's ability to cope. And one thing that I think is really, really important is no matter how we define kind of trauma and we think about it, one of the things that's most important is to remember that experiencing a traumatic event does not mean that one will develop a mental health condition or have long-standing effects. And we'll talk about why that's really important shortly. And some recent data from, well, I guess not quite as recent anymore, but from the World Health Organization in 2017 showed that 83% of individuals will experience a traumatic life event at some point in their life. And so one of the things that I think is important to also know from the trauma literature is that recovery from trauma is actually a natural process. When we talk about one of the biggest problems, it occurs when this natural process breaks down or something interferes with it. And OCD is one of those things that can interfere with this natural process across the course of time. So as humans, we are physiologically hardwired to recover from trauma and traumatic experiences. And I think what's a really great stat to remember is that 50% of those who experience a trauma will show full recovery within 3 months. And so while we know that trauma is incredibly prevalent and can have longstanding effects, we also know that over half of individuals will go through that natural recovery process as anticipated. We also know that there are in some individuals, something may get in the way of this, or the event or the number of events themselves may overwhelm someone's ability to cope and go through this natural process. And in those instances, there's a lot of things that can occur, more so than just PTSD, but including generalized anxiety disorder, depression, complex or complicated grief and bereavement. It can also include OCD or substance use disorders. And there are certain things that we know kind of may actually increase the likelihood of someone to of this process breaking down, including the degree of the threat, the duration or frequency with which the traumatic events occur, also one's proximity to the event in the case of things like natural disasters. But in those instances where this process breaks down, the thing that people think about the most is PTSD, or post-traumatic stress disorder. Now, when we think about this process breaking down, I do want to kind of highlight that the prevalence rate of PTSD is around 7%. And so again, this kind of reinforces the fact that experiencing a traumatic event doesn't directly lead to PTSD, but it is one of the possible outcomes. And I'll kind of reinforce why I think this is really important as we move forward as well. So when we think about PTSD, just to kind of talk about this briefly, because I know we're kind of talking more about OCD within this lecture, but PTSD is immediately following a traumatic experience, the development of symptoms associated with re-experiencing. So this could be intrusive images, thoughts, or recollections of the traumatic event, flashbacks, dreams, nightmares, as well as kind of pervasive avoidance or attempts to avoid things that remind one or trigger reminders of that traumatic event. There's also cognitive and shifts in mood. So kind of these what we call negative alterations in mood, where you might see things that look sort of like depression, or kind of beliefs about the world as a whole may shift, that the world's a dangerous place, people can't be trusted. Things in that realm where there's kind of this negative bias to engaging in the world following that trauma due to that impact. And then changes in arousal and reactivity. So this is one that people think about the most, such as like being hyperarousal, where someone's kind of feeling like they're always on edge. They're looking for that next thing that might be dangerous, maybe feeling keyed up or on high alert at all times. And so when we kind of take this into context in terms of PTSD and OCD. And when the two kind of combined, we do know now that they actually they co-occur, comorbid more than we actually realized. So there's some data that's come out showing that the risk for OCD is about 10 times higher in those with PTSD than in the general public. We also know that comorbidity of OCD and PTSD is associated with more severe OCD symptoms. Interestingly, it's not associated with more severe PTSD symptoms. So this comorbidity does seem to elevate OCD-specific symptoms. And there's a lot of emerging studies, some wonderful studies by a colleague, Dr. Caitlin Pinciotti, looking at how does trauma type and how does PTSD actually influence certain domains of OCD. One of the other, initially when this kind of conceptualization first came out, the idea was that following a traumatic event and the development of PTSD, that over time, if untreated, those fears kind of generalized out into other areas of the world, thus developing into comorbid OCD. But as we've gotten more data, what we started to realize is that the prevalence or the comorbidity rate is about 19% between OCD and PTSD, and that there's about an equivalent number of cases where OCD develops before PTSD or before the traumatic event, as to where individuals develop OCD following the traumatic event. And then about 20% develop it in the same year. And when we think about treatment, this is actually incredibly important to think about, because there's also some research that came out from Fontenelle and colleagues that actually showed that based on the order of onset of symptoms, there's variations in the clinical presentation, variations in comorbidity, variations in the prevalence of things like self-harm or suicidal ideation. And so when we think about this from a treatment perspective, so for those of you that are clinicians and researchers and providers, it's important to also think about the order in which symptoms onset. And what does that mean for the clinical presentation and for what would be recommended for treatment, which we'll talk about shortly. And one of the things I do want to talk a little bit about, as I was kind of mentioning, we're hardwired to recover from trauma, but when OCD is present before a traumatic event or develops at the same time as PTSD symptoms, OCD can be one of those things that tends to interfere with the natural recovery process. And for those of you in the audience who experience OCD, this probably comes as no surprise that OCD, in the face of uncertainty and in the face of danger, kind of wants to try to control everything, right? And we know that traumatic life events are common in those with OCD. And sometimes when we're overwhelmed or stressed, we might fall back on the things that we feel the most sense of mastery over to try to cope with those. And in a lot of cases, just given how prevalent OCD is and the way that it integrates itself into all different aspects of life, sometimes that thing that we might fall back on is our OCD rituals, because we're used to trying to use them to gain a sense of certainty, gain a sense of control, or neutralize uncomfortable feelings. And over time, OCD can kind of develop to be this maladaptive coping mechanism that essentially allows someone to avoid traumatic memories or reminders. Unfortunately, that also means that by avoiding those reminders and avoiding those memories, we never get the chance to process them fully, to make sense of them, to move through that natural recovery process. And it tends to intensify the distress associated with those memories and reminders over time. One of the other things that's, I think, is really important is that trauma and PTSD also have an impact on uncertainty and the ability to tolerate uncertainty. And we also know on the flip side that the more someone engages in mental rituals, for example, the less confidence that we tend to have in our own memories, the more that we try to use mental rituals to gain certainty about them. And this can also interfere with that recovery process in PTSD and trauma, as the mental rituals may distort the experiences and make it harder to process them across time in the way that we would otherwise. And so all of that, I just kind of wanted to use that to set the stage a little bit to talk about what does this mean for treatment? What does this mean for OCD treatment? Because this is a question that I get a good bit. And a lot of times I've heard many talk about the idea that are feeling like, well, when I'm in OCD treatment, I'm not allowed to talk about my PTSD or trauma, or when I'm in trauma treatment, they don't want me to talk about their OCD. And unfortunately, I know many individuals have felt like they've kind of just been referred back and forth. And so my hope for today is to kind of give a little bit of data to show that we can actually treat OCD and PTSD together. that there are integrative kind of emerging data and emerging research on integrative treatments, as well as parallel treatments where two treatment providers, one who specializes in trauma and PTSD and one in OCD, may actually be able to really seamlessly work together to help someone move through the process of both. And we'll talk about when that might be warranted versus when a more kind of what we call sequential approach of treating one first and then the other might make the most sense. The first thing to consider when thinking about treatment is I really encourage everyone to think about, is there an interaction between the PTSD and the OCD symptoms? What we have found is it does seem the order of onset and the way that there seems to be two main paths. One is this idea of what we call static comorbidity, where the OCD and the PTSD symptoms tend to stand apart. Typically, this might occur when the theme of a traumatic event doesn't necessarily overlap with the theme of feared consequences or obsessions in someone's OCD symptoms, where they kind of just stand separately. And in these instances, you can kind of treat them separately and be really successful in that idea of treating the primary one, the one that's causing the most interference first, and then moving on to the next one. However, we have found that there is another presentation that tends to come up, what we might call dynamic or merged comorbidity. So in this instance, we actually see that sometimes the themes of the traumatic event and the themes of one's OCD may actually become intertwined or overlap. And where we'll see that it almost gets really difficult to distinguish between what is PTSD and what is OCD, what is trauma related, and what is those kind of obsessions about the uncertainty focused obsessions. And so this first came up in 1991 where there was a case study talking about what we call post-traumatic OCD, where there's a functional connection between the feared consequences. And so in that sense, the feared consequences of the OCD and the experience of the trauma and PTSD overlap in theme. And what we realized kind of started to happen in this sense is that the OCD kind of functions as this umbrella where it's protecting an individual from having to connect with or experience the trauma-related memories, stressors, thoughts. And in a sense, the rituals are essentially those maladaptive coping mechanisms, protecting someone from having to re-experience some of the trauma-related symptoms. The tricky part becomes in that instance, when going through exposure and response prevention, as you start to peel back the layers and peel back the rituals and resist the compulsions, there might be a rebound effect where someone might experience more intense PTSD symptoms, which may make it harder to resist the rituals or reinforce like, oh, this obsessional fear might come true or could come true or has come true in the past. So what's keeping it from happening again? And in these instances, that's where we do see sometimes that this can actually have a negative effect on treatment, where many people will feel like I'm just kind of ping-ponging between really intense OCD symptoms and I start to get some traction there, and then my PTSD symptoms pop up and overwhelm me. And then I'd make a little traction there, but it's hard to really process the events because my rituals are so kind of all-encompassing. They're keeping me from engaging in treatment the way I would like to. And so when that happens, I think it's important as a provider to look for the connection between symptoms, try to see, is there overlap between them or not? And if there is, one of the first steps that I always recommend is for an individual and the provider to work together to try to differentiate, learn to differentiate what is PTSD, what is OCD, and where do they overlap? And really help everyone gain a really kind of solid, comprehensive understanding of what is OCD symptoms, what are PTSD symptoms, and where do they interact or overlap kind of in the middle. Because that will really help you guide treatment. And for those of you that are going through it, it can be very helpful in kind of getting a sense of control over or understanding of what it is that's happening and help the process not feel quite so overwhelming. Because in those instances, you can kind of say like, all right, if it's PTSD symptoms, here are my treatment strategies for my PTSD symptoms. If it's OCD symptoms, I know I can use exposure response prevention, ACT strategies, I have my game plan. And then as you gain kind of more confidence on both sides, then you can work to kind of target those overlaps with a little bit more confidence in both sets of skills and use both sets of skills as necessary for those areas that are kind of connected or overlapping. And so one of the ways that I think is important to think about this is noticing what is the difference between PTSD and OCD. So when we think about thought content, PTSD tends to be more focused on memories of a specific past event, where OCD is definitely more future focused. and sometimes when it does focus on the past, it's focused on the what if of the past. It also tends to be a little bit more generalized and not kind of associated with just a single event, but the possibility of a lot of different types of events that might occur. What if this happened and I didn't realize it? What if this does happen in the future? What if X, Y, or Z comes true? What am I going to do then? Additionally, while repetitive behaviors are seen in both, in PTSD, the repetitive behaviors tend to be focused a little bit more on preventing the trauma or that specific experience from reoccurring, and are focused on safety, like kind of maintaining this feeling of safety and control. And while a lot of times that can feel like OCD, the method sometimes is just a little bit different. And what we know with repetitive behaviors in OCD, they tend to focus more on the how you engage in that repetitive behavior matters. A little bit more in OCD than it tends to in PTSD. Those repetitive behaviors also tend to become more complex and more rigid over time. The more you do them, the more you try to get that sense of completion. The other thing that I think is really important is that repetitive behaviors in OCD are trying to help someone get towards a feeling of absolute certainty or 100% certainty about a situation. Where in PTSD, it tends to be more focused on once I feel safe, then I can kind of move forward. I'm doing this as a safety cue or safety behavior. The focus on 100% certainty isn't quite as intense as it is in OCD. Similarly, we see kind of some of these subtle differences in avoidance patterns, where in PTSD, the avoidance is more about avoiding painful emotions associated with a specific event or past memories of that event or triggers, where in OCD, the avoidance is typically trying to avoid feelings of uncertainty and all of that comes with it. One of the other things I think is really important is to highlight is how one relates to their thoughts. In PTSD, thoughts tend to be this thing that are avoided. But in OCD, while there's avoidance of thoughts, the avoidance is usually an attempt to control them. So in OCD, a lot of the time focuses on how can I control these thoughts? How can I neutralize them? How can I make sure that I never have them or anything similar to them by doing X, Y, or Z or doing a certain ritual or behavior? And how can I prevent this feared consequence from coming true? That in OCD, that general relationship of thoughts are to be controlled, where in PTSD, thoughts are to be avoided and not engaged with. Tends to be one way to separate too. What is OCD and what might be PTSD? One other thing I did want to highlight, and I want to open it up to questions a little bit as well, is when there's comorbid OCD and PTSD, one of the things that can really be a challenge, especially in exposure and response prevention, is addressing what we might call dissociative symptoms, or feelings of detachment from a mental process or your body feeling. People talk about feeling like I'm in a dream or feeling like I'm watching myself do something in day-to-day life. I'm not actually participating, but just watching. Dissociation is quite common in response to extreme stressors and is something that we see more of in PTSD. The challenge is that it does tend to get in the way of exposures and exposure learning. And so if you're someone who is engaging in ERP and also has a trauma history or diagnosis of PTSD, and you're noticing when you're doing exposures, it feels like you kind of like lose touch with what you're doing and sort of dissociate or start. I know in one talk that I gave, someone described it really well, like pulling the ripcord on your parachute, where you're just kind of get overwhelmed and then your brain's like, all right, I'm out. In those instances, it's really important to talk about that with your provider and work on what kind of grounding skills can you use to bring yourself back to the moment. Because when dissociation takes place, the goal kind of shifts. At that moment, the goal is to bring yourself back into the moment, because even if you continue the exposure while dissociating, that inhibitory learning tends not to really take place in the same way. So a lot of times what I'll encourage people to do is develop a good set of grounding skills that they can do and also teach individuals to notice, like, when am I getting close to that line of dissociating? If I can see when it's coming and know what skills to use to keep myself from dissociating and bring myself back to the moment, then the goal is, once you do that, to re-engage in the exposure. And that's a way that we kind of continue forward with ERP and OCD treatment, even in the midst of dissociative symptoms, and practice catching the dissociation before it takes place. And so kind of as I kind of wrap this up and open it up to questions, I did want to just give a little bit of data. And while this is still an emerging field, one of the things that we have seen, and this is some data also from intensive treatment on OCD, that we see that those with high rates of trauma experiences and trauma-related experiences and symptoms, one of the things we see the biggest impact on is actually treatment motivation. That early on in treatment motivation for those with significant trauma histories and comorbid PTSD tends to be much lower. But the great news is that over the course of treatment, that gap closes and motivation increases significantly. And you can see on this chart here that at about week 4 in intensive treatment, we see a significant increase in treatment motivation for those with comorbid PTSD. And I really think that this is important because this makes a lot of sense if you think about it from kind of a transdiagnostic lens, where if someone has experienced trauma, the what if factor of OCD can mean something a little bit different. Because what if this 1 in a million thing happens? It can become, what if this terrible thing happens just as it did before? And so it can feel that much harder to take the risk of embracing the uncertainty that goes with exposure and response prevention. But I think it's really important to highlight too that over time, that if you're going through treatment for yourself, the more you can stick it out, that over time that motivation will catch up. The confidence in your ability to sit with that uncertainty and to lean into it, even though you may have these traumatic experiences in your past, can grow over time significantly. And as you can see here, by week 8, that gap is actually quite small, and there's no significant difference in the level of motivation across after week 8, which I think is really important, that it may take a little bit longer to get going in treatment. And I think this is also for clinicians and providers, that the trajectory of treatment is going to look a little bit different. But the outcome can still be highly positive. But it might take a little bit longer to get started, and that's okay. The goal is to kind of focus on how can we enhance those features and those aspects of your life that you're motivated to get back to? How can we enhance motivation at the beginning of treatment to kind of close that gap even a little bit quicker? When we look at treatment outcome, while we do know that in outpatient therapy, comorbid OCD and PTSD, especially when there's that dynamic comorbidity or that functional connection, does tend to have worse outcomes over time at outpatient therapy. What we are seeing is that this might be more of an issue of dosage than treatment not working. Because when we look at intensive residential treatment, that's a high dosage of exposure response prevention and a high treatment dosage, we actually see that there's no significant differences in outcomes between those with OCD versus comorbid OCD and PTSD at discharge. And I think what's really interesting is that while those with trauma histories have higher OCD severity at admission and at the beginning of treatment, and higher depression scores at admission, and they do tend to have slightly higher symptom scores at discharge, I think the main takeaway here is what we found is that over the course of time, those with trauma histories actually show greater change from admission to discharge than those without. While their symptoms start a lot higher, they actually make up that ground really fast. And so you can see this across kind of the first, looking across time here at the bottom, you can see that while there's a big gap here, that gap gets a lot smaller. And so I think the key takeaway I always like to show is that experience of trauma history or comorbid PTSD is not a rule out for successful OCD treatment. While the start of it might be a little bit slower, and there may be some adjustments that are important as clinicians to make in terms of enhancing motivation, helping individuals differentiate between PTSD and OCD symptoms, with a high enough dosage of treatment, treatment still works and works quite well. And that change can be incredibly rapid once it gets started. And so, you know, with that, I'm going to kind of open it up. I see there's some questions coming in, so I really want to kind of talk a little bit about that. But I really wanted just to give a little bit of an overview to share that there are treatment approaches that work. We have empirically based treatments for PTSD and OCD that are both incredibly highly effective. And one of the greatest things about them is they're actually based on similar principles. When it comes to fear learning and tolerating uncertainty, the principles of the gold standard treatments for PTSD and OCD are very, very similar. And when you've learned one, it's really easy to learn the subtleties of the other. And so you can learn both really effectively and have a great toolbox that sets you up to treat both OCD and PTSD and move forward with your life. So hopefully if you take anything away from this, it's that the presence of PTSD or trauma does not mean that treatment won't work. Treatment might look a little bit different, but it can still be highly successful. And so with that, I just want to say thank you all for joining us.